Hello everyone, welcome to Surgery Dada. So today I have decided to discuss a very important topic for my surgery residents and all the surgery enthusiasts. And the topic that I shall be discussing is a topic from adrenals, and that is pheochromocytoma. So when we talk about pheochromocytoma, what are the things that we know? We all keep on talking about that typical 10% rule and this and that. So I would discuss that, but indeed I would discuss the most important thing about what is the classical approach for pheochromocytoma. So when we are talking about the concept of pheochromocytoma, it's a neuroendocrine tumor basically. It's a neuroendocrine tumor arising from adrenal medulla. So it's not arising from adrenal cortex, it's arising from the adrenal medulla, and this is what is very simple thing. Do you know that they follow a typical 10% rule? And what is that 10% rule? That 10% of them are malignant. Now what is the concept of they being malignant? Do you know only capsular invasion is not a criteria? Presence of distant metastasis. So distant mets, this is what is very important. Then an elevated level of Ki67, this is again very important. So Ki67 is elevated, distant metastasis is present, and this is again we have pheochromocytoma severity index. So PSI levels are also elevated. This is the only you can say criteria for calling it to be malignant. Merely presence of atypical cells, this is not going to qualify for this. Next is 10% of them are bilateral, 10% of them are you can say typically present in kids, 10% of them are extraadrenal. So we need to understand that pheochromocytoma arises from the chromaffin cells of the adrenal cortex. But when we talk about the extraadrenal, the similar thing which is happening outside the adrenal, what are they commonly addressed as? They are addressed as paragangliomas. So they are known as paraganglioma, and this is what is very important. Now when we talk about the pheochromocytomas, what are they doing? So a pheo is causing an excess, you can say excess norepinephrine. So excess of norepinephrine, along with that there will be excess of epinephrine also. So because of the excess epinephrine or excess norepinephrine, you have that classical symptom complex. And what is that classical symptom complex? The patient will have palpitation because of sympathetic stimulation. So they will have palpitation. They will also have headache. They will also have hypertension. Now what is the classical problem with this hypertension? Now this is an adrenal gland, and adrenal gland is an endocrine gland which is always having that pulsatile surge. So whenever there is release, there will be an episode of hypertension, and that is why this is known as episodic hypertension. This is what is very important. So episodic hypertension, palpitation, headache, and along with that we have diaphoresis. So these are the classical features of a classical pheochromocytoma. So whenever we have a patient with diaphoresis, palpitation, headache, and plus minus or plus episodic hypertension, this is what is suggestive of, you can say, a pheochromocytoma or maybe paraganglioma. When we are talking about something about the paragangliomas, what is the most important thing that we need to understand? That how does this paraganglioma come into role play, and what are and how are they different? So paragangliomas, they also have, you can say, the similar things. So they are considered as extraadrenal pheos. So they are also known as extraadrenal pheo. So when we talk about extraadrenal pheo, the next question that is asked is, where are they commonly located? They may be located at any point of, you can say, any part of your body, along the sympathetic ganglion or sympathetic trunk. They may be seen around the carotid body. You must have heard on chemotectoma or carotid body tumors. They that typical liar sign on CT angio. So we have a lot of places where they can occur. But still you need to understand the most common site for paraganglioma is the abdomen. And where in the abdomen? Yes, this is again very important. So this is near to the, you can say, aorta, and anywhere from the crus of the diaphragm up to the bifurcation of the aorta. So up to the bifurcation of the aorta and crus, this is the range. And do you know they are mostly located slightly left of the bifurcation. So the most common site for them, the most common site is slightly left to bifurcation. Do you know what are these organs commonly known as? They are classically known as organ of Zucker-Candle. So organ of Zucker-Candle. So when we talk about organ of Zucker-Candle, this is nothing but the classical, you can say, the most common place for paraganglioma. And I'll tell you something interesting about the organ of Zucker-Candle also. Now let us try to understand that when we talk about a pheo versus paraganglioma. So pheo versus paraganglioma, students, when we talk about this, it's very important for us to understand. Pheochromocytoma will have elevation of norepinephrine. So when we talk about norepinephrine, so this is elevated in pheochromocytoma, this is elevated in paraganglioma also. Now next we talk about epinephrine also. So norepinephrine we have seen. Now norepinephrine to epinephrine we require an enzyme, that is PNMT. Yeah, phenyl N-methylenamine, I think something like transferase, it is that PNMT enzyme. So this is an enzyme which is crucial in converting you can say norepinephrine to epinephrine, and this is present in adrenal medulla. So since it is present in adrenal medulla, therefore even the pheo has epinephrine elevation also. So norepinephrine, epinephrine is elevated. But this paragangliomas, they lack the enzyme PNMT. And when they lack, therefore this norepinephrine is not there. The only exception to this is what is very important. The exception to this is the organ of Zucker-Candle. Now when we talk about organ of Zucker-Candle, what is so special about organ of Zucker-Candle? Let us go to the embryogenesis. So you see that this is the neural trunk, this is the neural, you can say primitive neural trunk from which the things started to arise. So this is the primitive. So embryogenesis I am talking about, embryogenesis. So when we are talking about this classical neural trunk, there were lot of cells which were migrating, and they were migrating and they were getting collected, and they were getting collected to form something which is known as adrenal medulla. Now what happened? So cells started, or the tissue started to migrate from this neural trunk to form the adrenal medulla. So there was a time around 8th week of life when the adrenal medulla was formed, and then an order was declared, okay, this is houseful, now we don't require any other, you can say, sympathetic tissues. Now the in transit molecules, or you can say in transit tissues, the in transit tissues of the, you can say, sympathetic, you can say, ganglion, they just got freezed at the place where they were. So an order was passed that okay, adrenal medulla has formed, now we don't require, so neither they can go back, so they stay at that very same point, and they actually formed paragangliomas or organ of Zucker-Candle. So if we see the organ of Zucker-Candle, so they are the one who would have, they were having a potential to form what, students? The classical adrenal medulla, but they couldn't. Why? Because there was developmental delay. So they inherit that same PNMT. So they carry, therefore they contain this PNMT, and since they contain PNMT, therefore it's very important for you to understand that there is increase of epinephrine also, and there is increase of norepinephrine also. Now let us start with the classical approach. So let us talk about the classical approach of this, you can say, approach to paragangliomas, or you can say pheochromocytomas. So when we talk about a patient who has a classical suspicion of, you can say, palpitation, headache and diaphoresis, and along with that hypertension. So you are thinking that this could be paraganglioma or this could be pheochromocytoma. So when you're suspecting it, you need to understand that there is something which is known as metanephrines. So plasma metanephrines and then urine metanephrines, because ultimately epinephrine, norepinephrine will be broken down into VMAs and metanephrines. Metanephrines being the most stable product or stable breakdown product, we always search for them. So if you are searching for something in the urine, you need to collect a 24-hour specimen, and that is not very easy. It's a cumbersome process. Students, if you are expecting something in urine, that has to be present in blood first. So what we do whenever we have a suspicion of the pheo, the first line investigation, this is what is very important, is not the urine metanephrines, it is the plasma metanephrines. Now you would say, sir, is this investigation of choice? I would say never. Why? The plasma metanephrine has just one, you can say, advantage. What is that? It is having a negative predictive value. So if plasma metanephrine levels are low, virtually this confirms that it could be anything but not a what, students? A pheo. So pheochromocytoma is ruled out. If plasma metanephrine is found to be elevated, now this is what is very important, that now it's the time to confirm it in urine also. So therefore now the investigation of choice will come into role play, that is 24-hour urine free metanephrines, and this is what is very important. So it's a 24-hour free urine metanephrines. Now when you talk about 24-hour urine free metanephrines, there could be a possibility that it is elevated. Students, if it is elevated, then you have confirmed a diagnosis of what, students? A pheochromocytoma diagnosis has been confirmed. This is what is very important. Now this is, if the 24-hour urine metanephrine is not elevated, so I would say that it is low. Do you know, once the plasma metanephrines are elevated, the urines are not elevated, then you need 2 consecutive specimens to rule it out. So therefore you have to go for a repeat urine 24-hour free metanephrines. Now if these repeat free metanephrines, they are found to be low, I hope you understand that now the pheo has been what, students? Ruled out. If the repeat metanephrine is found to be elevated, students, the diagnosis of pheo is what, students? Confirmed, and it is what is very important. The next very important thing is that when we are talking about the urine metanephrines, there could be possibility where it is neither high. Now this is what is important, it is neither high nor it is what, students? Low. So in a basic sense, I could say that this category belongs to something which is known as equivocal. Now equivocal means it is not crossing that threshold that I would say high, neither it is negative. So there could be 2 reasons. So equivocal could be because of 2 reasons. Either it could be because of a tumor which is a weak in nature, or it may be because of the brain. So central stimulation from the brain is surging that. So therefore in that case you will use a stimulant, you will use a suppressant to the brain, because you cannot suppress a tumor, you can suppress the brain. And what is that? Alpha 2 agonist. So clonidine suppression test. So if I go for a clonidine suppression test, 0.2 you can say mg per kg, 0.2 international units per kg is what we go for. So we give a short injection and then we measure it. So clonidine suppression test. So clonidine is going to act on the brain. So if the metanephrine level, they decrease, that means that it was never a tumor, it was because of the brain activity, and therefore what is ruled out, students? The pheo is ruled out. If the metanephrine level, there is no change, then what does that mean? That means that the tumor, this is where you will make a diagnosis of pheo. So pheo is confirmed. So this is what is very important. Now students, either it could be pheo or it could be, you can say, paraganglioma. You know that there is something belonging to that same family. So now the next task is localization. Now when we talk about the classical concept of localization, the investigation of choice for them is MRI of the abdomen. Now when we go for MRI of the abdomen, you get to see on T2 images, on T2 weighted images, you get to see classical glow, and that is what is referred often to a what? Light bulb sign. So that is what is a classical light bulb sign. Now when we do MRI, it's very important for us to understand that if MRI is negative, what does that mean? That means that yes, there could be paraganglioma, not in the abdomen, anywhere else. Or students, if the age of the patient is less than 55 years. Students, if you want to read this topic, this is beautifully given in Sabiston and also in MD Anderson also. So when you are doing your surgery residency, do check these two books. They are very important. Sabiston and MD Anderson, they are very important for these two topics. One is this and another is CA breast. So if you suspect this, that means you are suspecting paragangliomas. So now the DOPA PET scan, or students, or you can say gadolinium DOTA Tate scan also, DOTA Tate scan. This is very important. This is far better than MIBG. What is MIBG? Meta-iodobenzyl gonidine. Now, therefore, you understand that investigation of choice is always a what investigation? Biochemical investigation. And this is for the diagnosis. And investigation of choice for the localization, answer is always what, students? Radiology. So when you talk about radiology, it is MRI, and biochemical, it is 24-hour free metanephrines. Next is, let us see, now you have made the diagnosis, you have localized. Next is the management or the treatment of the patient. Now this is what is very important. You know that we have to do surgery, so pre-op preparation. Now why is pre-op preparation very important? You need to understand that whenever we want to touch pheo, now this is like a, you can say burning, you can say hot ball, or you can say it's like a hand grenade, anytime it can rupture or burst. So if you touch the adrenal and there is sudden release of these catecholamines, or you can say epinephrines into the blood, you will be having malignant hypertension, and this will be actually the cause of fatality or the casualty on the table. So what you need to do, the pre-op preparation, you need to mask those alpha receptors. So alpha blockers, and this is what is very important. We start with phenoxybenzamine. So phenoxybenzamine, this is what is very important. 10 mg, this is started as OD. This could be escalated up to what, students? 40 mg. Now the moment you give this, the patient shall complain of what? Nasal stuffiness. So presence of nasal stuffiness, actually this is what is very important. Nasal stuffiness, this is indicative of adequate block, and this is what is very important. Students, I have launched my app. Now my app is available on, you can say, iOS also. It's there in the Play Store. However, it is still under, you can say, some changes are being done. It's still under reconstruction. But yes, majority of the features are working. So do download and check the other things also. I would be taking all your classes. Complete surgery for the residents would be covered in this app. Along with that, there would be, you can say, lot of Q banks to practice for your NEET SS. For international students also, there is a lot of content. We have the surgical videos of all the, you can say, majority of the surgeries, and keep on updating them. Then you can have a free hands-on access also if you want. You can book it along with the purchase of the app. You can book the free hands-on training at my centers, any of my centers in, you can say, Dwarka, in New Delhi. And for the international students, yes, I would give you the date for the Dubai center. So you can pre-book your, you can say, hands-on for Dubai center. But I would, you can say, give a deadline for that, and I would give the ample of time for that. Anyways, let us come. So alpha blockers are started, phenoxybenzamine, and then alpha blockers followed by beta blockers. So students, don't start with the beta blockers. It will be just reverse. So remember, this is started 2 weeks prior. So started 2 weeks prior to the surgery, and this is started 2 days prior. Why 2 days prior? It will control the rate and the rhythm. And then you need to operate. During surgery, you need to understand one very important thing, that phentolamine is the injection, is the drug of choice to control the intra-op hypertension, and then you need to go for surgery. Post surgery, now this is again very important, the post surgery we need to start alpha agonist. So this is again important, up to 2 weeks, and that is why we also go for preoperative fluid loading. Why? Because the moment you remove them, there's a fall in catechol levels, vasodilatation, and that is why preoperative fluid loading is important. Now when you're talking about surgery, now this is again very interesting. Now in surgery, if the tumor is less than equal to 6 centimeter, or if it is more than 6 centimeter, less than equal to 6 centimeter, we prefer to go for lap adrenalectomy, and this is what is very important. And if it is more than 6 centimeter, we go for open adrenalectomy. This is very simple. When you go for lap adrenalectomy, yes, in a different video I'll explain you the port positions, what is an open book approach, what should be the left side of the page of this book, or what should be in the right side of the page. So it's different on the right side, it's different on the left side. So that I will cover separately. And now when we are talking about laparoscopic, so we need to remove the specimen. For that you can give a classical phalansteal incision and remove that. So I hope you enjoyed the small crisp video. I'll be getting more such interesting videos for you. Till then, bye bye.